All right, friends, by my clock, we are right at the top of the hour. Again, I just want to thank each and every one of you for taking time out of your day to join us for our March webinar. Today's topic is really a great one. I'm hoping that a lot of you on this call have already been working to help your clients understand all of the Part D changes. But I love when we have an opportunity to tap an industry expert who can come in and not only share some of the details behind all of the IRA and Part D changes, but also give you an opportunity to ask questions and get other tips to help you as you're out there in the field helping your clients. For those of you who don't know me, hello, I'm Carrie DeVore. I am your Regional Sales Director. I am speaking to you today from sunny Arizona. And of course, we do have our special featured guest speaker today, Bradley Clarkson with Devoted Health. I'll introduce him more properly here in just a minute. But before I do that, I do want to share just a couple of things. A few of you on this call may be new to Fidelis. I want to give an extra special welcome to you as well. If you're not already fully familiar with Fidelis, let me introduce you. Of course, Fidelis is a nationally recognized FMO. We do support agents and agency throughout the nation. So we have four brick and mortar offices, so Arizona, Colorado, New Mexico, and Tennessee. But we support agents and agencies everywhere. We help you with access to carrier contracts. We can help you with both local and national support, getting you connected to the right people to help you as you're building your Medicare career. I could go on and on about different ways that Fidelis is here to support you, but I do want to encourage you, if you are not yet contracted through Fidelis, if you have questions, please take a screenshot of this page because it is going to have just a few contacts who would be glad to connect with you. You are welcome to reach out to our nationwide toll-free number of 1-855-872-6565, and one of us will be glad to help you. But I also would love to introduce you to a few key members of our Fidelis support team. This is our sales leadership team. I'm Carrie DeVore. Again, I'm here in Arizona, but I do support all of the states you see in green on the nice map of the United States. My partner is Brad Willard. You'll see that his primary contact states are the lighter blue shades, and he's also the regional director working with our East teams. I work with the West, including Marisa Canold, who is our beautiful, talented, wonderful, energetic director out of Colorado. And as you see, she also has become our leading expert on all of the northern states that you see in the darker shade. And then I could never forget our East Coast champion, Nick Santmeyer, who covers all of the purple states that you see. Do reach out to us if there is anything that we can help you with, whether it's questions from today's presentation or if you need help with other contracts, especially Devoted Health, who is sponsoring today's featured speaker. Speaking of resources and things that Fidelis does provide to the agents, and something that ties in perfectly with today's session. For those of you who are not familiar with our agent portal, it is fidelisagents.com. Anyone who has contracts through Fidelis will get full access to this site. And I'd like to highlight for you, under the agent tools, when you log in, you do have access to a lot of information, a lot of content to help you that is right at your fingertips. But today I want to call special attention to the Marketing Hub. Aside from all of the flyers, postcards, every bit of collateral that you can imagine that we have both in English and Spanish, I do want to draw your attention to the client presentations that are already loaded up easy download for you that you can insert your own contact information and just plug and play. You have a ready to go educational presentation that you can use with your clients in community meetings. And there is one in particular that is specifically speaking to what we're going to talk about today with the Inflation Reduction Act and the Part D changes. But I know you didn't come here to hear me speak. So I'd like to, with that, welcome our very special guest speaker, Bradley Clarkson. He is a pharmacist with Devoted Health. If you're not already familiar with him, he does have a lot of experience, 10 years of experience in PBM, health plan pharmacy operations, Medicare compliance, and drug therapy management. So Bradley, we are so honored to have you as our guest speaker, our resident expert. And with that, I'm going to let you take this away.
Thanks, Carrie. Uh, Again, welcome everyone. Thanks for joining us. And I think we should have ample time for questions. I guess before we get started to plug, because a lot of information is always, a lot of questions are, is this going to be recorded? Yes, this session is going to be recorded. And then the very last slide in this deck has some 3 links to take-home resources that can, help you if you're referring back. So we'll get to those at the end of the presentation. But the take-home resources are basically a quick like video or a YouTube video on navigating Medicare.gov Plan Finder for like putting in your drug costs. Frequently asked questions on like the Medicare prescription payment plan, um, and we also have an M3P payment calculator link that you can also just ask Google. Shout out Google's new AI pilot Gemini 2.5 is out today. So the searches are pretty easy if you're looking for that, but there are ample Medicare prescription payment plan calculators out there if you just ask Google. But I've included a link to that at the last slide. So just wanted to advertise those take-home resources before we get into the rest of the discussion and Q&A. All right, so getting into how is Part D changing? I'd say 2024 and 2025, really since the IRA was signed into law by former President Biden, has changed a lot of the Medicare drug coverage landscape and introduced quite a few provisions actually, and 2026 has some new ones. But this year, 2025, is the main one that changes how Medicare beneficiaries experience their out-of-pocket costs. So, we've just went through an annual enrollment season. Open enrollment season has about 5 days left. And then, the remainder of the year, we will have people that are aging in, have special enrollment periods due to catastrophes, unfortunately, or other things like that. Maybe changes with their Medicaid eligibility or things like that as well. So we do have people still throughout the year. And plus the coveted 5-star plans have continuous enrollment throughout the year if people want to move to a 5-star plan. And so that's maybe what we're looking at, for you through the rest of the year in 2025. But these provisions for cost share are really effective starting now, but they are going to be the same in 2026. And so just getting into, what changed for members last year to this year, some of the questions you might have been getting as people start to use their pharmacy benefit this year. Maybe they loaded up on 90-day supplies in December and they're just now going to the pharmacy again for their new Medicare plan. So what members are going to experience this year is no more coverage gap or donut hole. The thing that people used to hit is sometime usually between May and September, where they went from their plan copays to like a 25% of the drug cost. It's just kind of like a regular insurance design now. You have a deductible phase if it applies to the plan. Then you have your coverage phase or your initial coverage phase, and then you have the final phase is the catastrophic phase, which is the $2,000 cap. So that's the second bullet. Everyone is capped at a $2,000 out-of-pocket max. This is measured on a scale called Troop. To get into some semantics, you can still refer to it as like a maximum out-of-pocket to your customers and members because I think that's the most understandable. Technically, there's a term called MOOP that is moved to a medical cost component. So that belongs to Part B. That's like their doctors and labs and things like that. So technically, in CMS terms, a MOOP is that, but you can still certainly just, refer to it as maximum out-of-pocket cost when talking with your beneficiary customers. And so no one's paying a dime for a drug after they've reached a $2,000 on that scale called TROOP. We have some examples in a few slides of how that accumulates and how that works, because it's called Troop, but I think that's a bit misleading. It's not really their true out-of-pocket cost. It's just like a scale to measure their liability over time. And then, this year again, we have the Medicare Prescription Payment Plan, or M3P. Some people call it MPPP. I think M3P is pretty catchy. It seems to be the most common reference point. And what that is members can just enroll into a payment plan. I would probably call it like layaway for drugs. That probably would be the easiest way to describe, in layman's terms, maybe a little bit for people, or maybe like a credit card with a post pay. And then continuing from last year, the insulin copays are all capped at $35 or less, and that's per like 30-day supply. So if they're getting like a 2-month supply, it's 2 times $35. And then vaccines that are Part D are going to be free. I've called out the common vaccines just so people know. It doesn't really affect a member or a Medicare beneficiary too much. It's more for the pharmacy, but flu, COVID, and pneumonia are under Part B. They're all free. They're not supposed to have member cost share for those vaccines. Um, we have a new pneumonia vaccine out this year, flu and COVID, hopefully every year. And then Part D pretty much covers like all the other vaccines, and they're also supposed to be free. Um, I put in there that they need to be on the CDC schedule, because if someone is like a avid traveler and they're getting some strange vaccine, maybe like a malaria or some other international disease vaccine, yes, it would need to be covered, but that's not required to be like, that's not on the CDC preventive schedule. And so for, say, travel vaccines, a member would have an out-of-pocket cost for that. But most other vaccines that are there to prevent American diseases are free, and B or D doesn't really matter. So just wanted to plug that there. We do have a question. I'm going to try to answer questions as they arise, or at least reference to um, that we'll get up there in another slide. So first we have a question from Mr. Reisman about if a client switches carriers mid-year, um, do their costs move over to the new carrier? And so where someone is at on a troop calculator does move from MA carriers from carrier 1 to carrier 2. There may be a slight delay depending on when they file their like plan election decision or things like that, but the troop, plans have to submit that information and it carries through, and their new carrier would continue their troop. Right, and then to bring on to Carrie's point, we'll probably get into coverage. I think I have a slide on drug coverage a little bit, especially with how Medicare Plan Finder displays certain drugs. So we'll get into non-formulary drugs in a little bit of slides. But good question, David. And we'll go to the next slide. Okay, so common plan designs. This is again for the drug coverage. Most Medicare formularies have 5 tiers. Some Medicare plans have a 6th tier that's like adherence drugs. These are drugs that are for generally blood pressure, high cholesterol, uh, and heart disease. So those are ones where they're usually trying to make it free to help STARS performance. Not every plan has that. Most plans are on a 5-tier formulary. And so if you're looking at in the marketplace, there are a couple different flavors of formulary, but for the most part, you're going to have generic drugs heavily on tiers 1 and 2. Tier 3 is usually reserved for preferred brand drugs that are better value to the health plan. And then tier 4 is usually considered a non-preferred tier, where there's probably another medicine that treats the same disease that is in a lower tier. So usually if it's on tier 4, there's something else that a member can use. And then tier 5 would be reserved for high cost or specialty tier drugs. Um, and CMS kind of publishes every year how expensive does a drug have to be allowed to be on that tier, and it's currently around $1,000 a month. That's like the minimum cost for a drug being able to be stuck on that tier. So that's our basic formulary design you'll see with most plans. Um, there is an increasing popularity of generic drugs being kind of scattered through tiers one through four. And most of the kind of lower cost traditional generics are still going to be on tiers 1 and 2, but you'll find on some plans, maybe some older, higher cost generics or some less commonly used ones. You might find them on tier 3 and 4. So we do probably still think of tier 3 and 4 as brands, but they're increasingly commingled, maybe with higher cost generics in how plans offer drug coverage and formulary design. Um, let's see here. And we did hit on basic terms, copay, fixed copay. It's 10, 20, 30, $50. And coinsurance is you're paying a percent of the drug cost. And so that kind of brings up the next question. How do I figure out the drug cost? Because I'm paying a percent of the drug cost. So I think you're going to get that question a lot, and we'll go ahead and move on to the next slide. All right, so let's see here. Public resources for plan drug costs. Medicare.gov is still probably the best tool. It's relatively user friendly. Obviously you can use it to compare plans and look at medical costs while you're there and not just drug costs. So you can look quickly at what someone's looking at for specialist visits and hospital stays and all of that. So it's actually a pretty well done website, and we do have obviously like Connecture and Sunfire and some different platforms that port in information maybe to help your workflow. Um, most drug costs come from Medicare.gov, even if it's like some other platform. There is a company called SureScripts that collects data. So some of your private platforms, maybe it's coming from a different company, but for the most part, Medicare requires all the Medicare plans to CMS says, tell us your drug costs, and they get updated about every 2 weeks. And then CMS publishes that information out to everyone that they can access it, and they plug in the cost information into their drug finder tool. So they're pretty good pricing. Drug prices do change, not quite as much as the price of eggs, but they can change from time to time. So this is always a caveat that you need to tell people when you're estimating. They're going to be close estimates, but drug prices can change. They're not fixed. Brands don't change very much through the year. Generics can. Um, and so just keep that in mind when you're letting people know if you're trying to do like co-insurance. It'll be close, but it can change um, over time, although usually not to a high degree. So kind of in a nutshell, what you do is you go to Medicare.gov, select drug costs and find plans, and then type in your drug names and select the strength and quantity. So lisinopril, 10 milligrams, 30 tablets per month, or so. Then you add as many drugs as you're interested in, and then click the view drugs and their costs screen from their plans. So when you get to a zip code and they show all the plans, you can filter by a plan carrier if you're interested in a specific carrier. But once you're looking at a specific plan, you want to click on the view drugs and their cost button. That's going to bring you to the section where you can see all the different drugs. I prefer to pick at least a retail and a mail order pharmacy so that a member can, or you can evaluate like the differences, or at least be mindful of that. So here I've got a screenshot on the slide to show what the cost might be of some common medications. I think these are all 6 of these are like on the top 20 most utilized medicines list. And so we've got atorvastatin, Eliquis, Jardiance, uh, lisinopril, Ozempic, Trelegy, inhaler, and you can kind of see when you go down to like the pharmacy name, you can click the expand button, and it shows you the retail cost, cost after deductible, and a cost after the out-of-pocket cap. The cost after out-of-pocket cap is kind of silly because it's always going to be zero. That's how the cap works. But the retail cost column is very useful to see like, okay, this is about how much every month this drug costs. So if I have to pay 25% of $600 for Jardiance, all right, I'm paying $150. once I've met my deductible, if I have a deductible. So I think that's useful
I
to
do want
check
to
out the
point
retail
out
cost.
something, Bradley. I
Hmm.
love that you have this here and the Medicare.gov. I do want to encourage everyone on this call that if you are using Medicare Center, of course, our proprietary platform that we provide for you free of charge, it will not only give you all of your retail costs and all of the same information that you would get from Medicare.gov, it'll also give you easy access to all of the plan documents in one spot, and you can move forward with your enrollment. So it's a great resource. The other thing that I have found is if you're going to some sites like Connecture or Sunfire, sometimes it will base your drug costs as though they were in the plan for the entire year. And as we know, we're in the last week of OEP. And of course, moving forward, we'll be helping T65s and others with SEPs who may be looking for what their drug costs would be just for the remainder of the year. So if they're aging in June, it would be a more accurate reflection of what those drug costs would be from June forward when they'll have their plan. So I just wanted to give that shout out. If you need help, or if it's been a while since you've gone into Medicare Center and you'd like a tutorial, make sure that you reach out to one of us here at Fidelis. We'll be glad to schedule a training for you. And just walk you through how to use this same information that you can use in one platform that'll allow you to go from start to finish with your clients. And then it does look like, Bradley, we did get another question in the chat from our buddy, David Reisman. He asks, can you clarify what the troop includes? My understanding is that the beneficiary pays the deductible, copay, and coinsurance. The carrier will pay the balance of the cost of the drug. Is the troop on an accumulation of what the member and the carrier pay up to the 2K max? That is a great question, David. The troop, it
Yeah,
takes into
I think we've got, yeah.
consideration the higher of either what you actually paid or what the average plan pays. Is that correct, Bradley?
Yeah, we have a slide. We'll probably spend a couple minutes on slide 7 on how the troop accumulates, but that's a great question. So I think
Do we want to put a
also,
pin in that until slide 7?
yeah, I think we'll be there probably in about 5 minutes. So
Okay.
yeah, that will be a good exercise. So these platforms and Medicare.gov do uh, they do calculate that in the background. I think it's important to understand, what it is. So we shouldn't necessarily have to manually calculate everything, but it's important to understand, I guess, the math behind it. But yeah, we'll do that in, I think, 2 slides. But that was helpful to know, at least like when I look like in the later months of Plan Finder. Um, I included the screenshot to show like what the retail cost is at a pharmacy, but in the drug coverage section, Medicare.gov, it shows you your cost per month. And so obviously, if someone's hitting the cap, those later months after they've hit the cap, it'll start saying 0 in those months. And so you can see it over time, and the math is accurate. So we will get into the true pick calculation in just a moment. Next slide, please. Uh, I think we'll probably look at, go back one. Sorry about that. Yeah, so we mentioned obviously these are estimates, and that pricing can change. It also actually changes between pharmacies, not incredibly so. Most people have copays for generics, and that's like the most variable costs. Brands are pretty consistent, but it can also change based on like which pharmacy you use, if it's like retail or mail order, Walmart or Publix, but not, again, usually a whole lot. So non-formulary medicines, each plan publishes a drug list known as a formulary, and these are drugs that are covered. They may require a prior authorization. They may also have limits on the quantity or require a step therapy through another drug, which means you have to try one drug before accessing the secondary, less preferred or less effective drug. Um, Non-formulary means you're not going to find the drug on a plan's drug list. So uh, the ways you can go about that are a person can talk to their doctor about, can you prescribe something else that's on my list for the condition, or go ahead with what's called a coverage determination, and the doctor or the member submit for a formulary exception, and the diagnosis and medical necessity of the situation are reviewed, and they may get it approved. That's fairly common because the formularies can't cover every drug. There's 50,000 drugs and so forth, and most formularies are um, composed of the most commonly and medically necessary drugs. So just to I guess caveat, like if you type in a non-formulary drug and you're going through Plan Finder, I'm not sure if your Medicare center is quite the same way, but if it's not on the drug list, it's going to show up as like not covered on the Plan Finder, and the full retail cost of the drug is going to get plugged into a member's out-of-pocket costs. So like if I um, plugged in some, let's just say it's like a $5,000 drug that's not on the formulary. If I'm going to Plan Finder and I look at like my out-of-pocket costs for the year, it's going to basically say I'm responsible for the $5,000 every single month, however many months are left in the year. So that is just, I guess, something to consider is that no, there's no guarantee that the non-formulary drugs get approved, by a plan. They have to undergo a review. However, that's a limitation of Medicare Plan Finder is that it's going to assign like the entire cost of the drug as if the member's paying it. In reality, most plans, if it's decided that it's necessary medically, a member is going to end up with some sort of cost share. They're not paying 100% once it's approved. Most often, it is going to be the tier 4 cost share. So if someone pays 35% of the cost of medicines on tier 4, that's usually what they're going to have to pay for their non-formulary medicine if it's approved for coverage. I think there's quite a few members, that are on a medicine that's in this bucket. So that's probably just something good to keep in mind, when they're trying to estimate the cost of that drug, because there's a little bit of a gap in Medicare.gov on assigning costs for those drugs. All right, the next slide. This is just a reminder for some commonly used brand medications by therapeutic category. I don't think I need to read all these, but you'll see, obviously, you've got blood thinners, you've got diabetes, you got inhalers for asthma and COPD, there's dry eyes, there's heart safety and cardiovascular outcomes, glaucoma, bowel and bladder. Everyone's got irritable bowel syndrome and overactive bladder when they reach a certain age. And so just for reference point, the different brands are kind of listed out there. So I'd say this is just a good reference slide to drugs that members are probably going to be taking, and that you may be trying to look at, what's the copay on these medicines. Since they're brands, they are going to be higher cost.
This is also a great reference for those of you who were with us for our last national webinar where we talked about CSNPs and special needs plans. This is also kind of a good clue. Some medications just tend to indicate that there might be an opportunity with a plan. Remember, CSNPs do allow year-round enrollment, so there is an SEP for that.
Great. And now the slide we've been waiting for, slide 7. So for Troop, the not totally true out-of-pocket cost is a scale that is looking at what's called the defined standard benefit versus what a member is actually paying. So Medicare's defined standard benefit is a $590 deductible and 25% of the drug cost after the deductible. And so when you're looking at Troop, it's either however much they would owe under the defined standard or what they actually paid. And it's the greater of those amounts. So like if my copay was $10, but my drug was $100 and I was supposed to pay 25% of that, I would get credit for a $25 towards my Troop because it's 25% of 100, even though I only paid $10 personally. So it's always the greater of those amounts. And then we see the phases here. You've got in the deductible phase, obviously up until you reach 590, the full cost of drugs go towards the Troop. And then when you get into your initial coverage phase, it's after the 590. It's that 25% or greater of member cost share, and then catastrophic phase 0. So we have, let's see, vaccines are always 0. They don't really count towards Troop. Members don't pay anything for the Part D vaccine, so they're kind of in their own little world or bucket. Insulins are a little different because insulins have their special pricing under the IRA. It's really just $35 per, like it's what what they're paying, essentially what they're out of pocket paying. So it's like the percent of drug costs, it's a little different. If someone actually, like for some reason, some of the insulins have gotten cheap recently. If someone actually only paid $20 for an insulin, then that'd be how much it went towards their troop. It'd be the $20. Um, or it'd be the $35. So just keep that in mind. People on like Lantus, Traceba, Toujeo, Novolog, there's a long list of products. Humalog, Keep It Fair, Levemir, um, they you know they accumulate differently in lower amounts. And so for David's point, let's go to the next slide. So we're looking at plan deductibles and troops. So I think the first point is up until $590, it's not percentage based, it's the full cost of the drug. So if you have a plan where the design includes a $590 deductible, that's pretty obvious. They're paying the full cost of the drug up until they reach 590. Um, then they will pay 25% after that. So here's an example of a plan that it was still more common than I would have expected this year, but there's a $0 drug deductible. This plan does not, there's no deductible phase for members. So how does that troop work? Well, they have no drug deductible. Let's say their cost share was $148. And again, the troop amount is 590. Let's see here. I guess the way to put it would be my cost share. Let's say I sign up for this plan and my deductible is 0. I personally pay $148 or $150. We'll round up. So $150. That's how much I paid. I get credit for more, right? It's always the greater of. So under the defined standard, I would have been responsible for the full cost of the drug. So not just my $150, or even if it was $10 and the drug was 100, it's the full cost of the drug up until $590. So we'll probably put that in the chat. That's just something to consider in those early months when someone's talking about meeting their deductible or meeting their troop level of the deductible. So I guess how that plays out in the real world is if you're looking at members who are considering only plans that have a $0 plan deductible for drugs, they're kind of starting out about $400 to $500 ahead. So they're like not really going to pay $2,000. It depends on their cost share and what medicines they fill and in what order, but they're basically starting ahead on that accumulation scale. And their plan deductible is $0, and then they pay their copay. They're getting credit for the difference between the full drug cost and what they paid in that deductible phase. We'll pause here. Does anyone have a question in the chat about the
Yes.
deductible phase? Because that's kind of
So
the weirdest. That's the weirdest phase.
David actually asked if the carrier pays on a member's behalf part of the troop. And I think this slide does answer that to some degree. Because if the carrier has designed their plan to have a $0 deductible as an example, that means that by design behind the scenes, they have. Because there's still that $2,000 cap, but as you can see in example 1, the client actually only came out of pocket by $1,558. They're done at that point because in a defined standard plan, they would have reached their $2,000 max. And remember, CMS is crediting the higher of the two, either what you actually paid or what the defined standard plan would have paid. So in essence, the carrier is picking up the costs, a big portion of the costs beyond that $2,000 mark when you go into the catastrophic phase. So yes, in essence, the carrier is picking up more cost. So when you see plans in your area that have a $0 deductible or a $400 deductible, as is shown in example 2, the carrier is taking on a little bit more than what they're required to do because of the defined standard plan. So I hope that helps. Those are great questions. And with that, are we ready for the next slide? Perfect.
Yes, yeah, I'd say the example 2 has some good like specific numbers on on that. But in a nutshell, you're seeing plans contribute dollars towards a member's troop cap responsibilities. And that's why a lot of members will not actually pay $2,000 over the course of a year. All right, so let's see. We have a member named Sally, and we have, say, a 3-drug regimen. And just to try to illustrate, where it might come out and some of the common math of the like defined standard plans. Um, let's say, your tier 1 generic, it's $10. Your tier 2 generic, it's $20. Tier 3 drug might be $150. And so, you're looking at the deductible phase. Again, the full cost of the drugs is going in. So Sally might have a copay of 0, 10, and 150. So let's say her tier 3 drug, either has a $150 copay or it's subject to deductible. The amount that's going towards troop, it's the full drug cost, 10, 20, 150. Then they get to their initial coverage limit. And now, all right, what's my copay? Sally paid $0 for her tier 1 drug. She still pays $0. But the cost is $10. So how much went toward her troop? 25% of the drug cost. That's the defined standard cost sharing. So she's getting credit for that 250 even though she paid $0. In tier 2 drug, the actual cost is $20. So 25% of that is only $5. But she's paying $10 as her copay for her tier 2 drug. So therefore she's getting credit for her copayment, not the defined standard 25%. And then tier 3, she's going to pay, let's say her tier 3 coinsurance was 25%. That's exactly equal to the defined standard. So that's pretty straightforward. She's getting credit for what she paid because it's equal to the defined standard. So hopefully that helps illustrate the greater of whether it was what you paid or whether the defined standard says you should get credit for more.
I just want to throw it out there because every area has so many different plans, and every plan is structured just a little bit differently on copays and deductibles. So if it looks a little confusing for you and you'd like a little bit of extra help, that is actually what your Fidelis team is here for. We would love to help you through that. Just reach out and let us know what you need. And are we ready for our next slide, Bradley?
Yes.
Perfect.
All right. This is just, let's see here for John. We're looking at troop accumulation over each month. And so let's just say this person is on a single tier 3 drug that is a brand and is $700, which is not that uncommon for some of the top used medicines out there. And so what they're looking at is, okay, I have a deductible. It's $590 defined standard. So I'm going to pay the full amount, of the drug plus basically the month 1 is a straddle claim. They would pay up to their deductible and then they'd be responsible for 25% of the remaining amount. So that would be $110, 25% of that. So that's what you're seeing. I'm sorry, you get the copay of $30 here in the initial coverage limit. So John's paying his $30 copay plus his $590 deductible. So that's his month 1 cost. Now he's met his deductible. His cost going forward is $30. Each month, his trooping is 25% of his $700 drug cost. So you see his troop amount is much greater than his actual payment amount, and that continues on, through the month 9. This person actually meets the cap, after 9 months of being on this drug, and now they are trooped out at above $2,000, and they would pay 0 from there on out. So there's kind of an example of maybe a single higher cost medication and how it might look going through the months.
That is a great example where a client will actually spend far less than the $2,000. Thanks for including that one, Bradley. Is this the same?
Yeah, this is the same, except it's got imaginary low-income subsidy applied. I think it's probably not necessary that we go through this, but the main caveat is, or the main take-home point is that low-income subsidy, also known as extra help, is something that members have to apply for separately. They should be encouraged if they're kind of on that lower income bubble to consider applying. And if they qualify, I think there's like 2 levels. It depends on resource limits and things like that. That's definitely something to have, conversations with your clients about. It can help them with their drug cost. And so kind of the take home point is that whatever plan someone with low income subsidy signs up for, their troop still accumulates kind of the same based on the plan they elected as if they didn't have low income subsidy. So that's just something to consider. I guess in another way to like take it away, low income subsidy dollars accumulate on a member's behalf towards the troop maximum. So even though John pays $12 uh, for that low income subsidy statutory copay for his brand drug, and he pays it for 9 months, and so he's paid like $108. Well, he's trooping out the full like defined standard amount. Like his accumulation on troop is not changing just because he has low income subsidy. That's probably the main takeaway to consider for plans. So that's why John would still troop out after September, and he would pay nothing for the next 3 months. So in a nutshell, low income subsidy dollars count on a member's behalf towards their troop.
Perfect. The most common question that I think a lot of agents have had this year is about the M3P plan. And I'm super excited that that's your next topic.
I had one. Can we just go back one slide just to, I think there was a question about it. I didn't know if Rochelle had a specific question on it.
Oh,
Um, but yeah, that would be, there's quite a bit of, I guess, reference information on this slide, but that was my take home point was that um, low income subsidy dollars count towards troop for members' behalf, and uh, kind of their accumulation behind the scenes is the same on the plan they select, whether or not they had LAS.
okay. Perfect. Well, let's go forward
Okay.
now with the M3P plan.
All right, so the M3P Medicare prescription payment plan questions probably are: how do I enroll? What if I get disenrolled, and what if I don't pay? These are common questions that we'll all try to address here. And so CMS introduced this, and you could call it like drug layaway or crediting to the plan. But what happens is someone signs up, and they now are going to pay their health plan for their drug out-of-pocket costs rather than the pharmacy. At the pharmacy, they pay nothing. They just pick up their drugs. After the month, it's like in arrears. So the month of January is over, and they get a bill from their health plan for their out-of-pocket share. So that's how it works, and that's good for just compliance and things like that. Um, and the idea is that member costs are sometimes high in the first quarter of the year. They may have a deductible in play, and this will help spread out the cost throughout the remaining months in the plan year. Um, it doesn't actually change how much someone pays ever. It's just changes how you pay. You pay to the health plan retroactively rather than upfront to the pharmacy, and you can spread it out, over a series of months. Again, it's optional. There is a thing called likely to benefit where CMS tells health plans that health plans have to tell members if they're on certain like higher cost medications, hey, we're sending you a letter, you may be likely to benefit. What you can do, as an agent going through someone's medication list, basically if they're on a brand drug, there's a good chance they might benefit. They can sign up in advance before they join a plan. They can also sign up at any point during the plan year. So we'll go for the next slide, but that's pretty much how you get into the plan. We talked about people who are likely to benefit. Again, really, any brand drug, they are probably going to benefit. Um, you could have someone who is on low cost medications and they incur, a need to have some higher cost medicine like in the middle of the year. Uh, they they can still sign up in the middle of the year, and then they would pay their higher out of pocket costs, say from May and June, throughout the remainder of the year. Just something to keep in mind. This spreads it out of the months left until December. So if someone's in, September, August, there's not very many months left to spread out their drug costs for. And so, later in the year, it's not as good of an option. But early in the year, they may benefit. LIS people, they don't have really high costs. They're not necessarily going to be They don't have deductible by statute for LIS, and so they're not necessarily likely to benefit. So that's just something to keep in mind on who could benefit. I also put in there someone who pays, like if they're only on 90-day supplies and they have a high copay once a quarter, if they prefer to pay that every month, they might be as someone to sign up for as well, just so they get monthly bills rather than a high copay every quarter if they're on long 90-day supplies. Next slide, please. All right, so how do you enroll? If you don't do it through your pharmacy or your PBM, they have to contact their health plan to enroll. Other most common question, what if they don't pay the bill? And so the billing is in arrears already, like the month of March is about to end. Then someone's going to get their bill for what happened in March later in April. And then there's usually a grace period. I think it's 2 months of like not paying the bill. And so if someone doesn't pay their bill, they're never going to be disenrolled from the health plan. That's not an allowable thing. But if they don't pay their member costs from the M3P, they can be disenrolled from the M3P program, which means they would just go back to paying the pharmacy for their medications when they go pick it up. And so that's really the consequences. You're still going to owe whatever amount you owe to the plan. It's kind of like just incurring like a debt to the plan. But if you don't pay it, you're still going to have that plan debt, but you would go back to paying at the pharmacy counter. When you switch plans, because this also happens a lot. Let's say you have a switcher. Yes, their troop amount is going to follow them. Their M3P election will not follow them. They will have to re-enroll with that health plan.
Hey, Bradley, what happens if a member is in default on their M3P? Let's say that they are in one carrier's plan. They've defaulted, they've gone more than their 2 months, and so they are no longer on the M3P. If they had a valid election period and moved to another plan, would they be able to re-enter M3P during the same plan year with the new carrier? Knowing that they had already defaulted this year.
Yes, so the M3P is kind of maintained by each plan, and so um, if you switch from carrier A to carrier B, carrier B, you can sign up with carrier B. You would still have your bills. You would still get like letters or bills from carrier A for the amounts owed, but they could sign up with carrier B, for that M3P if that's what they needed to do.
Perfect, thank you.
Next slide, please. All right, so here's just an example of someone who's likely to benefit. They have a high amount of costs in the first quarter of the year. If you took the M3P, signed them up right away and spread it out, this is kind of about how much you would pay throughout the course of the year if you took $2,000 and spread it out. Something to note, if you look at like January through April, it does kind of fluctuate. That's a weird thing about how the M3P is calculated. Every month, what someone owes is recalculated. And so it's not like you take $2,000 and it's not like $2,000 and you just divide it evenly over 12 and you pay $166 every month. Right? Someone's drug costs, they're going to change what prescriptions they filled or didn't fill each month. And so it does recalculate every month. That's why you see like a slight fluctuation kind of early on, and then it kind of stabilizes out. Next slide. All right, this person is maybe not a very good candidate for M3P. He pays, let's say he has drugs, he doesn't have a deductible for the plan he's looking at, and he pays $100 every month. He's not going to hit the $2,000 cap. And what that might do is set him up where he pays not very much for most of the year, and then he has high bills at the end of the year, which would probably not be desirable. And so that's an example of someone who may not be a good fit for the M3P. And that is probably the most commonly discussed items about how does M3P work, plan formulary coverage, how we calculate troop, and then as a reminder, the promised resource links for, I want to go through Plan Finder more at my own pace, maybe with a guide, common questions about the IRA, and then Again, you can ask Google for the M3P payment calculator. I included a link to one here. And we'll open it up for any general questions.
Thank you, Bradley. This was great information today. I know that everyone on this call appreciates the time that you spent not only putting this together for us, but sharing all of your insights. So we are going to open up the phone lines and the chat right now for any questions that you have. Remember that all of our carrier partners are happy to answer questions about this and more, as well as your Fidelis team. But right now we have our resident expert, Bradley Clarkson, and let's take advantage of this time. If you have any questions, we're going to stay on the line right here to field those.
Hi, Bradley. It's Marisa. I might have missed it, but just in case I didn't hear it, there's an important clarification on the M3P, correct? That once a member is enrolled in that, they cannot tease out specific drugs. It's an all or nothing program. So it's going to take into account their T1s and their T5s. You can't just say, oh, I want this program for my highest cost drug. It'll be everything, correct?
Right, that is a good question. It is all of their claims would be, enrolled that way. I don't think there's really probably, obviously lower cost drugs are not going to influence it as much one way or the other. But yeah, that's a good question. So it will be all their claims. Another thing that maybe is just member best practice, if you're advising someone who says, yeah, I intend on signing up for this M3P plan, with whichever health plan carrier I select, have them tell the pharmacy at the point that they're like getting their prescriptions filled, that they had signed up for it. Pharmacies are learning more at this point. They've learned more, but it's definitely helpful, that a member will inform the pharmacy of their election as well, because that will help the pharmacy with processing their claims.
So, hey, Bradley, this is Dave Reisman. So another question then on the MP3 or MP3, right? If someone's switching mid-year, say they move or it's an OEP or another special SEP, and they're already enrolled in the payment program through the current carrier, how does that get transferred over to the new carrier?
Right. So that is going to be, they would essentially have two cares that a member has to deal with at that time. They would be kept separate. So, if they were in carrier A and, they had a $600 balance on M3P, they would still have that. They move over to carrier B for the remainder of the year. They re-sign up with M3P for the new carrier. Their troop is carrying over, so like the calculations are accurate, but like they're still going to owe their bills to carrier A at the same time as whatever new bills they're accruing, to carrier B.
And then if there is a discrepancy, say they are moving, whether they are on the M3P or not, and they've spent X amount of dollars with company A, they move over. Company B now is assessing the deductible, but they already satisfied that with company A. What's the best remedy to take care of that issue?
So I would go through really member services for things like this. The main point there is to make sure that their claims are accurate and up to date. Yeah, there's sometimes a chance that, I don't know, if they end up never picking up a medicine or something like that, they left it at the pharmacy and the pharmacy returns it to stock, and now they no longer owe, or they no longer have a prescription claim counting, towards their troop. Sometimes that happens. Whereas before, like if the pharmacy's filled it, it's on the shelf but hasn't been picked up. If the pharmacy's filled it, it's still counting towards their troop. And so I would really just have them do member services to make sure their claims are accurate for where their troop is at, and then the troop of plan A should be carrying over to plan B, and they can get the billing correct that way.
Who's
There are
monitoring
situations.
that? I'm sorry. Who's monitoring that troop? I mean, because carriers don't talk to each other. So carrier A to carrier B. So who's the middle person? Is it CMS that is calculating and keeping track? Is that how carriers
Their
will adjust?
application, I think would be, what would we call it? It's arbitrated by CMS. And so when they leave carrier A, their new enrollment gets processed. There is some like enrollment information that gets processed from carrier A to carrier B.
Okay, thank you.
Hey,
Again,
Bradley,
just to
we've
clarify
actually
that,
had,
Elias here,
oh, go ahead.
Elias here, clarification again, CMS is getting records of the data between the two carriers during this period of time? Did you confirm yes or no?
So like the troop amount is on records that is submitted from the plan to CMS, and then when they join a new plan, those records come over as part of their like enrollment package to the new plan.
Good, thank you.
Okay, we do have a couple more questions in the chat that have come in. Lorena asks, if someone has 9 drugs and only one is a tier 3 through 5, do they still pay the entire deductible for that one drug up front? I'm assuming Lorena is referring to plans that may have a $0 deductible on tier 1 and 2 drugs, but has maybe a deductible on tier 3 through 5. And that's a wonderful question. Bradley, would you like to answer that one?
Yeah, that is actually some of the plans that Devoted offers is like that. And so there could be certain tiers of drugs on the formulary that are exempt from the deductible. So obviously if they're on one of those tiers, like say it's the generic tier 1, or say it's a STARS medicine for blood pressure and it's on tier 1 or tier 6, there's no deductible, and therefore they don't pay the deductible. But let's say they do have one drug that's like a tier 3 through 5. Let's say they're on a blood thinner Eliquis. They're going to pay the deductible up to their troop amount. So, I mean, if the plan has a deductible of $400, it gets into a little bit more member specific situation they'll have to look at. But let's say the deductible was $590. Remember, they're getting credit for the full cost of those 8 other, say, generic drugs. So even if those 8 other drugs are like $10 each, they might be paying nothing for them, but they're getting credit for those drugs towards their deductible. And so they're not really paying the full $590 deductible. They are getting their troop accumulation, and it's all those other 8 drugs. And then, however much they owe for that one more expensive drug like Eliquis. Hopefully that makes sense. But just keep in mind, all their drugs go towards their troop calculation, and a deductible goes with the troop calculation too.
Is there ever a time that it would matter the order in which they are filled? For example, if you're putting in all 9 prescriptions at the exact same time, are they counting the deductible? Would their deductible be more if part of it was processed before the tier 3, or less if part of the other 8 drugs were processed first, versus if they filled the tier 3 drug first? Is it possible that they would have to pay more of the deductible because it was just processed first?
Yeah, so there are effects of when people fill them out. So a lot of plans, if the deductible applies to every tier evenly, you're not really going to see this in place as much. But if you are like really getting into the math and like fantasy footballing the situation, yeah, your generic drugs, fill those all first, get the full drug cost troop accumulation credit, and then fill your brand drugs after that. And that would generally tend to maximize your troop accumulation.
Good advice. Thanks, Bradley. We did have a final question here in the chat, and Keith, you specifically said question for the end of webinar. Since the government subsidized the plans for 2025, do we anticipate that ending for 2026? And what do you think plan costs and changes may come? Ooh, crystal ball question.
Yeah, I think there was quite a few plan changes this year, maybe not as extreme as some were thinking about. So it's tough because of Medicare Advantage and PDPs are different. So prescription drug plans, there could be a large change next year. Medicare Advantage plans, I think it will be more gradual. But yes, plans do have a larger financial responsibility now under the IRA, and so there are kind of shifts a little bit in their coverage, and they're just trying to manage like how much they change their plan from year 1 to year 2 to year 3 to make it more gradual. But as a whole, the IRA has shifted more financial responsibility to health plans, and they're going to make updates to their benefits accordingly. But they can only do so much to their plan value in each given year. So we'll have to find out what the government says on extra plan subsidies, things like that. I mean, the payment rates are not too bad for next year, but every year Medicare kind of says this is how much we want to pay physicians and other practices and things like that, and so I think we're maybe still waiting another month or two for that. But that would be my prediction for 2026 is you'll still be encountering a few changes, just not as much as what you saw this last year.
All right. Well, thank you for that, Bradley. That was a bonus question about what we see in the future. And I really appreciate you addressing that and all of your time you spent with us. That does conclude today's webinar. I do want to remind you that you can reach out to any of us at any time. We're all here to help you. I'll bring this map back up onto the screen. If you need help from anyone on your Fidelis team, please reach out. We're all here to help you. Thanks again, Bradley Clarkson from Devoted Health, for giving your time, your expertise, and all of this great knowledge. We so appreciate you, and we appreciate each and every one of you for giving your time today too. We'll see you on the next webinar. Have a great day, everyone.
Thanks, everyone.